Good evening, everybody. Thank you for coming to another Tuesday night edition of the Honors Colloquium. I'm Jeff Bratberg, one of the co-coordinators, and if you've been to other colloquia, I am the voice of the questions that you get, so I want to make sure that you know who I am when I sit down here and take your questions. We do take questions at the end. CAPT Tosatto is also going to have questions using Poll Everywhere. You'll be seeing the codes that you text to that same number. So it's as if you're sending a text message to 37607. The instructions are at the top of the slides. There'll be some multiple choice questions that you'll use. And then at the end, you'll be able to either write questions on the note cards, or you'll be able to text or email those questions in. And people watching live can also do that. Want to point out, too, we saw this last week, too. We partnered with Slow Food URI, a student-run group, doing local food market on the quad. Had a great day today. With local food, local healthy food on the quad every Tuesday from 11 to 3. Stop by and support these vendors. Now I'd like to introduce the Dean of the College of Pharmacy, who will introduce CAPT Tosatto.
Thank you, Jeff. It is my pleasure to introduce U.S. Public Health Service Officer Captain Robert J. Tosatto, who is with the Office of the U.S. Surgeon General. Captain Tosatto is Director of the Civilian Volunteer Medical Reserve Corps, a division of the U.S. Public Health Service. He is the Principal Advisor to the U.S. Surgeon General and the Assistant Secretary for Health on issues of civilian volunteers and their participation in public health initiatives and emergency preparedness and response activities. He's a registered pharmacist who earned his bachelor's degree from the University of Pittsburgh School of Pharmacy. He also earned a master's in public health and a master's of business administration degrees at the University of Alabama in Birmingham. Captain Tosatto is an expert on and advocate for reducing disaster risk, building community resilience, and engaging young members of our society in these efforts. He is directly responsible for overseeing the establishment, implementation, and coordination of Medical Reserve Corps units and communities nationwide. Captain Tosatto has been with the U.S. Public Health Service since 1988. And he previously completed tours of duty with the Office of Global Health Affairs, the Substance Abuse and Mental Health Services Administration, and the Indian Health Service, including assignments and postings at the Navajo, Fort Hall, and Pine Ridge reservations. He's been deployed with his unit on a number of occasions, including response missions following the anthrax mailings in 2001, Hurricane Katrina, and several humanitarian and national special security events. He is a recipient of the U.S. Public Health Service Meritorious Service Medal and the Surgeon General's Exemplary Service Medal. No matter what we do, we will face more disasters in this country because of the world we live in and because of Mother Nature. Captain Tosatto confirmed that for me tonight at dinner, and so it's my pleasure to invite him to the stage now. Captain Tosatto.
Thank you very much. Hello. Well, hopefully I'm going to teach you something tonight, but also keep you a little bit entertained as we go along. So, as Dr. Bratberg mentioned, I'm going to start off with a couple of questions using the Poll Everywhere technology. One, just to give me a little bit of baseline about you, about the audience. So, if you can kind of play along a little bit, tell me a little bit about yourselves. Are you a student, a faculty member here, a volunteer, or a member of the community? So, what you'll do is, as you look at that code. So, for example, if you're a student, you will text 321120 to that number 37607. And this is really fun because it'll kind of change as you go along and start voting. So as you can see, I guess being in a university setting, it's not surprising that the majority of us here are students. Okay. Let's move on to the next one. So, looking at this, very heavy on students, some faculty, volunteers in the crowd. Thank you very much. All right. You heard the dean mention that I am director of the Medical Reserve Corps. How many of you work or interact with the Medical Reserve Corps, the MRC, in your community? And the bottom one is, I have no idea what that is. So as we look at some of these results, we see folks that know about the MRC and are working with them, folks that maybe know about the MRC but aren't able to work with them right now, and then we have a handful, about a quarter of the audience, that hasn't heard of it. Well, by the end of tonight, hopefully you will know what MRC is, and hopefully by the end of the night, I can convince you maybe to interact in some way, volunteer with or support the Medical Reserve Corps here in Rhode Island, and outside for those kind of at home. I believe it is important to be prepared for an emergency. From your perspective, true or false? What do you think? Is it important? Answer. There will be people who do not think this is important. There are more important things to be concerned about. People will believe that, absolutely. What I want to do is follow this up, because there's a logical follow-up to this question, isn't there? So I believe it's important to be prepared for an emergency, but do I actually do anything about it? So here's the true or false. I am personally prepared for an emergency. So have I said, yes, it's important, but now I've gone that next step and made some sort of, action or some sort of behavior to be prepared? And folks, those that say I am not, you're not alone. And we'll talk about this quite a bit, that false answer is what most Americans give. And finally, disasters are inevitable, and there is nothing we can do about it to reduce the risks. What do you think? True or false? Well, I'm hoping that the title of my presentation gave the answer away to this one, because there are things we can do to reduce risks. We can't necessarily prevent disasters, but there is a lot we can do to reduce risks. And I hope at the end of the night that all of you will, at least be able to describe some of those ways. So let's talk about some of those objectives. I do want to talk about the benefits of a focus on disaster risk reduction, and then talk about the ways that you, community members, health professionals, volunteers, can reduce risks through public health activities by reducing vulnerabilities and building resilience. You may be surprised to know that we're always in an emergency management cycle. There's not an emergency going on right here at this moment, but we're still involved in this cycle, if you think about it, in preparedness, in prevention, because there are things that happen before an event that you can do, and things that obviously happen afterwards when the sirens are going off and the lights are flashing. So we're doing things like preparedness. And what does that involve? So I asked you to answer that question earlier to say, are you personally prepared? But that's going to mean something different to a lot of different people. It's going to be having an emergency plan. Being able to communicate with your family if there's an emergency, if you're at work or at school. How do you get in touch? What I would encourage all of you to do is have a family emergency plan, knowing your evacuation routes, where to meet in an emergency. It may be right outside your house, but you need to know several different places. There may be a place in your neighborhood, somewhere in town. It may even be somewhere outside of Rhode Island or outside of your state, because there are sometimes you have to evacuate further. But having that plan in place in advance is incredibly important. Being able to communicate during emergency. Oftentimes communications is the first thing to go down. And that happens especially because everybody gets on the phone to say, are you okay? Yeah, I'm okay. What research has found, though, for, especially with cellular phone traffic, for every 1 minute cell phone call, 800 text messages could go through. So if there is an emergency happening, it's often best and easiest to send that message as a text. Are you okay? I'm okay. Very simple, but that can go through rather quickly. The other thing is if those circuits are down, when they're up, even just for a split second, that text message will go through, so you don't have to sit there trying and trying and trying. It'll go through. Having a kit of supplies for an emergency is very important. Some people will say have 3 days. Other people will say 7 days. Some people will say 30 days. What's important is to look at what the potential hazard is that is most kind of prevalent for your area, and then have the kits, have the supplies on hand. And this is really common sense. It's the basics that you need. Clean water, some food, some first aid supplies. You can get very, very fancy and buy lots of things because you do need to be informed about what the hazards, what the potentials might be. For example, it may be a zombie apocalypse that you have to prepare for, and so you want to make sure that you're prepared for that. This was a program done by the CDC late last year, early this year, and they used the topic of a zombie apocalypse to get people talking about preparedness, because a lot of times you see the hurricane pictures or the tornado pictures, and they're scary because that could happen to you. Well, CDC kind of turned this around a little bit and said, well, zombies are scary, but it's also kind of scary in a funny way. And this helps open up the conversation to say, here's what you need to be prepared for, kind of tongue-in-cheek, but those same things that you can do to prepare for the zombie apocalypse, having a kit, having a plan, are going to help you in a real emergency. And I know here on campus, Dr. Bratberg and probably some of you in the audience participated in a zombie drill earlier this year. So that is something that we do kind of encourage, is in preparedness to have drills. And again, your topic can be the hurricane, or it can be something like a zombie apocalypse. So we talked about earlier, I asked a question, do you feel it's important to prepare, and do you prepare? And that's, a lot of studies are done on that. A recent Red Cross study found that yes, most Americans feel that it's important to prepare. Their results were 7%. 7% actually do prepare. Other studies have had higher results, almost up to 50% of people who said, yes, I'm personally prepared. But when they broke it down into specifics, do you have an emergency communications plan? Do you have a kit? Then those numbers dropped off. So even the people who said, yes, I'm prepared, really weren't quite so prepared. So how about emergency response? So here in Rhode Island, last year you saw the effects of Hurricane Irene coming up and Tropical Storm Lee right afterwards. You've seen flooding, you see ice storms and snowstorms pretty frequently. This is something you see on the news about, responses. And you typically think of, the response, the first responders, the firemen, the law enforcement officers, EMS. Public health and medical folks are there as well. As you saw during H1N1, the primary responders were your health providers providing, vaccinations for flu. That's an emergency response, folks. Well, the topic here is Health, politics, and money. And guess what? Health, politics, and money all come into play in emergency response because this is very much a work in progress. There are a lot of things that are up in the air when it comes to emergency responses, especially when it comes to a public health emergency, medical surge, having providers that can provide assistance when needed in hospitals, liability protections when you're giving vaccinations, when you're getting into issues like quarantine. There are huge dilemmas when you're getting into cases where there is a standard of care during normal time that may need to be a little bit different during a disaster, when you have triage, when you're deciding who gets the care when there are limited resources. I mentioned public health. There are a lot of things that have to occur every day for a community to be healthy. Many local health departments are out there on the front line providing services to assess the health of the community, to provide services of education and health care to individuals. A couple of years ago, there was a public health awareness campaign that used stickers saying, "This is public health." And public health workers and students went around their communities and putting them on things that related to public health. Clean water, food, hand washing, cigarettes, tobacco control, seatbelts, injury prevention, bike paths, promoting healthy activity. So there's lots of things that have to happen for a community to be healthy. And there are staff and money issues, though. So this is a study done, survey of local health departments around the country by the National Association of County and City Health Officials, where they found that the average size of a local health department in staff is about 12 to 15 people, and their average yearly budget is $1 million or less. So as you look at all those things that we want to have occur for our community to be healthy, and then you think about the staff and the money, it's kind of a little bit of a weight challenge there, right? And then you have things like this. It's hard to believe, 11 years ago already. When you have an event like 9/11 occur, and you have an entire nation watching this and thinking, I want to do something to help. No, I don't want to do something. I have to do something. How many of you felt, obviously we have a lot of students in the audience that were young at the time, but how many of you felt like you had to do something that day and in the weeks that followed? Yeah, I was right there with you. Absolutely, I felt like I had to. And many people felt that, and they showed up at the crash sites in New York and at the crash site in Pennsylvania and in D.C. They showed up at local hospitals saying, I got to do something. Many of those people that showed up were medical professionals, showing up in their scrubs with their stethoscope saying, what can I do? One of my friends, one of my colleagues, Dr. Richard Hatchett, was one of those people. He was a resident in New York at the time, and he watched the buildings burn, and he ran down towards that area and said, I'm going to go help if I can. He wasn't known to the system, and he and many others, they weren't known to the emergency managers down there. He wasn't, credentialed. Sure, he's a doctor. He knows he's a doctor, but they don't know that. He hasn't been credentialed by them. There are a lot of people who show up at things and say, yes, I'm a doctor and I'm here to help, but they're really not. So you do want to make sure that their credentials are verified and that they're trained and prepared for an emergency. Following the federal building bombing in Oklahoma, there was a general call for volunteers. We need health professionals down here. Come down here and help. One of the nurses that went down had never been part of an emergency response before, wasn't trained, wasn't prepared. She went down there, she ran into the building to help, and she was hit by falling debris and was killed. She was not prepared for it. So that was one thing that came out of the lessons of 9/11, was that, yes, we need people that can help, but we want to make sure that they're identified in advance, that they're prepared in advance, that they're trained in advance so they know what to do if they're needed. About a month later, in 2011, we started hearing about anthrax being mailed through the U.S. Postal Service. We saw congressional staff members. We saw postal workers lined up for medications to prevent disease. I have personal experience with that. I was deployed on 6 missions in response to the anthrax mailings. Day 1 in the Capitol, providing medications to the congressional members and staff members. It was a mess. It was chaos. It was long lines of people, and we were putting ciprofloxacin in baggies and talking to groups of patients, getting this medication, trying to get them through as soon as possible. It was chaotic, but the next day we were a little bit more organized. And then when we were providing the services at DC General Hospital for postal workers, we were a little bit more organized. And then when I was deployed to take what we had learned so far up to New York City for the postal workers up there, we were getting pretty darn well organized. And from that experience, several things happened. One was where now we have points of dispensing, or pods, that are routinely practiced and drilled. Those are based on the mechanisms and processes and procedures that we developed following the anthrax attacks. But one of the other things that we learned, I learned, and in talking with my colleagues that responded as well, was we thought, we're pretty darn lucky that this was just thousands of people coming through here, because if it was bigger, if it was tens of thousands or hundreds of thousands or millions of people, if we had to provide medications or vaccinations to an entire city or an entire state or an entire nation, we didn't have the capability to do that. And so, between the lessons learned from 9/11 about needing volunteers and needing to, do the volunteer management and identification in advance, and then the lessons we learned from anthrax, very similar, that we would need these volunteers, a program was developed, an idea or concept was developed called the Medical Reserve Corps. And Dr. Richard Hatchett, who I pointed out earlier, was one of the early proponents of this idea, and he testified to Congress about the need, and he talked to folks within HHS who were developing similar ideas. And so this group came together to create an idea, a concept of, could you develop local groups of volunteers that would do the training and preparation in advance to prepare and respond to emergency. But the idea was also there to create, a strengthening for public health on a daily basis. So it was kind of dual use. Strengthen public health and then be ready to respond to emergencies when necessary. And that is what we have seen develop, is this national network of these local groups. And some of the keys to success, I know there are many of you in the audience that are dedicated volunteers with the Medical Reserve Corps. Couldn't do it without you. Unit leaders of these Medical Reserve Corps units that do the volunteer management that's necessary to engage the volunteers, to train them, to prepare them. But then also working with partners like universities, like health systems, like emergency management within the community to make sure that there's support for the Medical Reserve Corps unit, but also outlets so that those volunteers can work and that they're integrated in with the other response agencies. So we started in 2002 with nothing. 0 volunteers, 0 MRC units. And this idea was created as a demonstration project. So we saw 42 communities in the first year that received kind of grant funding as a demonstration project, and another 120 MRC units the next year that received that funding. And around that time, in late 2003, I was brought on to be the director of this program, because it was a demonstration project before that, being kind of tossed around within the Office of Surgeon General. But they realized really quickly on that, this is something that communities want and that they need. And I was brought on to say, Dr. Carmona, the Surgeon General at the time, said, you need to take this out and sell this to other communities to make sure that they get this great benefit of having a Medical Reserve Corps unit in their community. And so we saw the Medical Reserve Corps grow over time. 2009, 2010, when we had H1N1, last year 2011, to the point where we are now. This gives you the dots of where all the MRC units are located. But I like the following map. This one gives a little bit better perspective because it not only provides a dot of kind of that zip code of where the MRC is based out of, but the grayed out areas are their jurisdictions. So we have MRC units that cover, a small town. Most of the MRC units in Massachusetts are, a single town or a couple of towns. We have MRC units that are based in a county or a small region within the state with multiple counties. Or like here in Rhode Island, we have a Medical Reserve Corps that covers the state. There are currently just under 1,000 MRC units across the nation. We're in all 50 states, and we're in most of the territories. So we have come a long way from that humble beginning 10 years ago. You'll see that there are white areas that are, not covered by an MRC unit. And yes, we're still working to, target those areas, because ultimately what we want to see is the entire nation covered by this great resource called the Medical Reserve Corps. So a quick question for all of you. Do you think that all Medical Reserve Corps volunteers are health professionals that have a license? So they're a licensed physician or nurse or pharmacist. So I lectured earlier today with a class, and I think they're all answering this because I gave them the answer earlier. So the falses are correct, that MRC volunteers kind of run the range. So a little, in some ways, the Medical Reserve Corps name is a little bit of a misnomer, because not everybody is medical. And sometimes when people see Reserve Corps, they get a little scared because I'm in uniform. They think, oh, do I have to join the service? No, it's civilian volunteers in local communities who want to work on public health activities and prepare and respond to emergencies. About 2/3 of the Medical Reserve Corps are medical or medical-related public health professionals. But about 1/3, kind of this big spike here in the middle, are the non-public health, non-medical volunteers. These are folks that can help with leadership, administration, logistics, communications, all those things that don't require a clinical, a clinician or a medical provider to provide. Of the medical clinical professions, nurses are by far the largest, with almost 60,000 nurses within the Medical Reserve Corps. And I encourage Medical Reserve Corps units across the nation to think very broadly when they're recruiting for volunteers. Because honestly, we need a large pool of individuals within each community to volunteer, because we know that in any given type of activity or event, not everybody is going to be able to volunteer at that time. They may be working in their regular job, or they may need to take care of family. What we want to make sure is that there is as large a pool as possible from which to draw, and so that's why we encourage a broad recruitment of health professionals and non-professionals. And I also encourage broad recruitment in kind of age and level of training. So many students volunteer with the Medical Reserve Corps. We have folks who are actively practicing in their profession, or they may have a license but aren't actively practicing. So think about, healthcare administrators who may have a pharmacy license or a nurse license or are a physician. They may not practice in that field every day, but they may be able to volunteer using their professional skills. Or think about the retirees who have a wealth of experience to share with the MRC and giving back to the communities. So let's talk a little bit about activities. What do MRCs do? Well, they do a number of things. And our goal for this year for MRCs to report activities was 10,000. Because, I am in the government and we like numbers, so we always kind of put performance measures and goals on things. So I guessed at, 10,000. I'm not sure we're going to reach that, but we've already passed it. We still have another couple days left in the fiscal year. So that's been fantastic. So this is one way of looking at activities, broad focus areas. But I'm a bit of a geek, and I looked at all those 10,000 plus activity reports, and I pulled out all that text. And how many of you have heard of Wordle? So you can make a word cloud. So what I did is I took all that text and pasted it into Wordle, and it pulled out the terms that are most frequently come up. This is, I think, the 75 most frequent words that came up in those activity reports. So volunteers, obviously, working on preparedness, health, training, response, outreach, providing information, flu, operations, skills, training. So this gives you an idea of what some of those common themes are throughout those activity reports. Honestly, I kind of like the art aspect of that. I might print that out and use it as a poster. When we talk about emergency response, what are we talking about? Well, talking about a number of things. So here in Rhode Island, you guys had the best results in the country by far in your response to H1N1. 84.7% of your school children were vaccinated against the flu. Normally, 20 to 30% rates of vaccinations. That was tremendous. That was a tremendous, response that the MRC had here in Rhode Island. But even nationwide, we saw over 50,000 MRC volunteers involved in over 3,000 activities for H1N1. Early on, providing health education, talking about hand washing and cough etiquette, using your sleeve, not your hands, and talking about, when you should be staying home if you're sick. And then when the vaccine was available, providing the vaccines to communities through mass vaccination clinics or through school-based clinics like here in Rhode Island. But what else? Large public gatherings. You think about it. Okay, it's a lot of people getting together. Most of the time, nothing happens. Maybe a few, bumps or scrapes. But, as we saw last year with the Reno Air Show, sometimes things can go wrong. That happens. But having a Medical Reserve Corps on hand to provide that first aid, but also being there to assist if things do happen, is essential. And I know the MRC here in Rhode Island does a lot of those types of events, marathons, the Operation Sail down in Newport earlier this year. Snow and ice storms, when power's out, being able to put folks into shelters so that they stay warm, or conversely, when it's you have a heat wave and power goes out, and then you need to put people in cooling stations or shelters. Having staff, Medical Reserve Corps volunteers that can assist with that is very important. Floods, hurricanes, tornadoes, providing rehabilitation for responders. Think about the firefighter that goes into a wildfire, and they're wearing lots of gear. They get overheated. They need to come out, cool down, get their blood pressure checked. MRC units across the country are beginning to do some responder rehab for that. One group in Illinois actually brings therapy dogs with their responder rehab as well. So as the firefighters cooling down, they're getting something to drink, they're able to sit there and pet the dog. It's been shown to really help reduce their blood pressures. So we saw this earlier. There's things that you can do before a disaster, and there's things that you do afterwards in responding and recovering. Responding is sexy. It's exciting. You get that adrenaline rush. The lights are flashing, the sirens are going. But it's also very expensive. And typically, the responders there immediately, the lives are saved or lives are lost, and then the responders go back home, or they go back to kind of doing what they normally do. So it's not necessarily sustainable. And then communities are in recovery, sometimes for a short period of time, sometimes for years, sometimes they never recover. So as we think about this, the costs, what makes more sense and is more cost effective is to do what you can before the effect, before the event, to either avoid or at least reduce the risks of that disaster beforehand. For every dollar spent in reduction activities, that saves, in some research, $7 to $10. So think about that effect in a disaster of how much money could be saved for the local community, for the state, for the nation. And typically these risk avoidance and risk reduction efforts are more community-based. They're more ingrained within the community and are therefore more sustainable. It's not the Lone Ranger or the cavalry coming in to save the day and then leaving. They're instituted there right in the community. So preparedness is something you do before impact. Personal and family preparedness, like I talked about earlier, is very important for the Medical Reserve Corps. In fact, it's one of our core competencies that every Medical Reserve Corps member should be personally prepared for an emergency, have that family communication plan, because honestly, if they are not personally prepared, the possibility or the potential of them volunteering goes down significantly if they're worried about their families. So we want to make sure that that preparedness is there. But also for the MRC unit, making sure that the MRC unit is prepared by doing necessary training so that they understand kind of incident command, where their role is in an emergency, doing drills and exercises with their community partners so everybody knows their roles, so that they're already working together and not just meeting for the first time at the emergency site. But then also kind of reaching out to the community and helping the community to prepare by doing, outreach events to teach about preparedness, showing people what's necessary to have in an emergency kit, talking to folks about emergency plans. September is National Preparedness Month. This is a great time to talk to your neighbors, to talk to your families about preparedness. And one of our partner groups, Safe America Foundation, several years ago and continuing, denoted September and October as a season of drills, so that not only are you doing the planning, but actually practicing a little bit. So I encourage all of you to do that, is to practice your emergency plan. It might be for your family, do a house evacuation in case there was a fire, know where to meet. Or maybe it's a texting drill, making sure that everybody in your family knows how to text to each other to say, are you okay? Yes, I'm okay. But we can even do more than that, just preparedness. We can talk about disaster risk and talk about how to potentially reduce those risks that are inherent with a disaster. Because when you look at risk for a disaster, it comes down to being a factor of the hazard itself and the vulnerabilities of that individual or that community to those hazards. And that vulnerability is made up of the exposure to the hazard, the susceptibility to that hazard, but it's inversely proportional to their resilience, their ability to kind of adapt. So if we talk about hazards, we're talking about those kind of natural things that happen, like tornadoes and hurricanes, but it's also man-made, terrorism or a chemical spill, things like that. Ultimately, it's difficult to prevent hazards. You can't tell a tornado to go the other way. You can try to prevent terrorism, but as we know, that doesn't always work. But that's part of what the government agencies try to do, is to prevent. Can try to reduce hazards from occurring, but oftentimes it's difficult. So where do we focus our reduction efforts on is the vulnerability. And those are the circumstances, the conditions within that community that really make it susceptible to that hazard. So think about vulnerability a little bit. What leads to vulnerability? Poverty, age, ethnicity, gender, all of the above? I think you're seeing this as a little bit of a trick question. So when you think about vulnerability, it really comes down to most people are vulnerable in some way. Granted, there are people who are more vulnerable than others. But what we see time and again is that the most vulnerable are usually the most significantly affected by disasters. And there are a number of factors that lead to vulnerability, poverty being one of the biggest. But, lack of experience with the disaster, not being prepared, leads to vulnerability. Inadequate health care or a high burden of illness. Those who are healthier before disaster are often healthier during or following a disaster. So there are a number of factors that lead to vulnerability. along with that is the exposure. Are you in the hazard zone? Are you in harm's way? You may be vulnerable, but if the hurricane hits 3 states over, it's not a risk to you. Are you susceptible? Are you truly at risk? If that hazard comes, are you more susceptible? So think about it, exposure. You are in an area that floods. Are you susceptible if you can't evacuate, if you don't have the money to evacuate, or if you can't swim, or a number of different reasons that you're susceptible? Now, what about resilience? As I mentioned, it's inversely proportional resilience, and that's really that ability to kind of adapt, overcome, maybe even come back stronger following an event or after a hazard. So if you want to reduce risk, you can try to reduce the hazard, but as we said, that's kind of difficult to do. Or you can reduce the vulnerability by reducing the exposures, susceptibility, or increasing the resiliency. It's fairly simple. I'm not going to test you on this later. So where does MRC come into play? Well, MRCs, Medical Reserve Corps units, Medical Reserve Corps volunteers, can help to reduce exposures by helping with evacuation planning, or if a need comes for evacuation, by helping to implement an evacuation or providing shelter care for those that were evacuated. Building resilience and reducing susceptibility. I'm going to talk about these a little bit more, because I strongly believe that volunteerism builds resilience. When I think about resilience, I think about what we have here are the 4 R's. Robustness. And that's that inherent strength within the community system that helps it to kind of withstand kind of that hit. So it's having a strong social network, social cohesiveness before. It's having kind of government and nonprofits and other agencies and businesses working together before an emergency. It's breaking down those silos, those kind of stovepipes and of communications, and breaking those down and reaching across and working with each other. Redundancy. Having contingency plans in place is often needed, especially when we're talking about emergencies or especially healthcare. Having that medical surge care capacity. This is really somewhere that volunteers can come into play. Resourcefulness. That's being able to kind of identify problems, generate solutions, and acting to solve them. Having a plan is great, but we know that things don't always go to plan, so being resourceful is important. And then rapidity, being able to implement this quickly so that the community can recover as soon as possible. Now, resiliency isn't going to be generated or mandated or dictated by any local, state, or federal government regulation or policy procedure. It really comes from the ground up, from everything we can do every day to connect with each other. It's working with each other to understand what the hazards are and how we might better prepare for it. It's talking to our neighbors, maybe an elderly neighbor who might not have the resources or the connections, their family may not be close, and saying, okay, if power goes out, what can I do to help? It's volunteering. It's giving blood. It's doing all those things that we as Americans can do to help each other out. Ultimately, it's being empowered and encouraged to act. What about susceptibility? How can Medical Reserve Corps, how can we all reduce susceptibility? And one big way that the Medical Reserve Corps does this is through our public health activities. Preventing diseases, promoting health, providing health services, especially for the most vulnerable. Now, I want to be able to tie this all, not to just what the Medical Reserve Corps does, but how we can focus on this at all levels. So if you think about it from a national level, one of the outcomes of the Affordable Care Act was the creation of a National Prevention Council that is headed up by my boss, the Surgeon General. And what this group is doing is trying to look at the goals and activities and priorities. And if you haven't seen this, I really encourage you to take a look at it. It's actually one of the better developed and written government documents out there. It's fairly small too, so it's not a doorstopper. But it has some very specific goals, some great recommendations for localities, and good measure. So looking at what can be done, but then also how can we measure if it's being done. And it also aligns a lot of work that is already being done through Healthy People or through the First Lady's Let's Move campaign. So as you look at this, it has a very simple goal to increase the number of Americans who are healthy at every stage of their life. Pretty simple. Doing this through healthy and safe community environments, providing clinical and preventive care services, empowering people, like I mentioned, with resiliency, and eliminating health disparities, that susceptibility piece. And there's some areas to really focus on, some priorities that, for most of us that have been involved in health or healthcare or public health, are pretty recognizable. Don't smoke. Avoid drug or alcohol abuse. Eat healthily. Get regular activity. And these are things that, through a number of different organizations, Medical Reserve Corps being one of them, but all kinds of organizations at the local level, we can help to prevent disease, but also help to change the conversation from disease to health. We are very much focused on disease in our nation, on illness, when the conversation really should be about health. Thinking about the overall physical, mental, and social well-being of an individual, not just the absence of illness or disease. So a couple of examples. This one I just pulled from a news report yesterday. Change the Future West Virginia, program supported by the Centers for Disease Control and the state of West Virginia, looking to increase physical education in their schools. They're doing it during school hours by hiring more PE teachers, having more gym classes, but also opening up the school after hours so that parents can join their kids with some physical activity in the gym or maybe having some classes there. Zumba was one that was mentioned, and basketball games. But also trying to make more healthy choices of food available in the school for lunch, at sporting events. Talking to the local Walmarts about having junk-free aisles. And talking to the convenience stores about having healthy options like fruit and vegetables in those convenience stores. So again, this is one way that that community is working on it. Program that's done in partnership with the Million Hearts campaign, trying to prevent the incidence of heart attack and heart disease. This is one that just came up this week. It's called Team Up, Pressure Down. It's partnering pharmacists with their patients to lower blood pressure. So get more pharmacists taking blood pressures and talking to their patients about how they can reduce blood pressure in their lives. And then finally, right here locally, Shape Up Rhode Island. Hopefully all of you have heard of this. And this is a way to create teams, a little bit of competition amongst the teams to focus on healthy eating and healthy activity. So tracking team members' steps, the minutes that they exercise, the fruits and vegetables that they're eating, the sleep that they're getting. How many of you are involved in Shape Up Rhode Island? I know a number of students are. This is fantastic. You are serving as role models for your communities, for your families, for your friends. Ultimately, you are going to have a profound effect, not just on your own health, but potentially on others. By doing that, you are helping to make your community less vulnerable. You're reducing disaster risk by wearing that pedometer. It's kind of weird to think about because you don't think about wearing that pedometer as being a way to reduce risk, but ultimately it is. So here, at home, here in Rhode Island, some of the Medical Reserve Corps activities, as I mentioned, a lot of the large public gatherings, treating and releasing patients, taking that burden off the local EMS, but also providing health screenings for those that are most vulnerable. Across the nation, Medical Reserve Corps units are involved in numerous activities, almost daily, providing medical and dental screenings. This one down in Texas with Operation Lone Star. Over 60,000 services provided. Providing screenings, talking about obesity and obesity prevention, providing vaccines, providing free medical care to uninsured, physicals, back-to-school physicals, immunizations, medical and dental services, medication take-back, helping to prevent the abuse of those medications that might be laying around. These are all activities that Medical Reserve Corps units do. This is just a handful of them that I pulled off of recent activity reports that we receive. But these are going on, as I mentioned, daily. And I encourage all of you, as you kind of go out, to think about these and how you might become involved in some activities similar, whether it's through your job or whether it's through other volunteer or other efforts that you do. So I'm going to start to wind down because we have plenty of time for discussion and questions. But I want to go back to my objectives, and I want all of you to think about this. Could you describe the benefits of a disaster risk reduction focus if you were asked? And then if you remember the second objective, ways to enhance public health, reduce vulnerabilities, and build resilience. This tells me if I did my job okay. They're watching these. And if you can't, please, I'll be around afterwards. If you want to discuss this more, we can answer it in kind of the group questions, but also in individual questions, because I do think it's important for all of us to be able to describe and discuss the importance of this. But you're not done yet, because I'm going to give you some homework. I want you to think about this a little bit. Think about the potential hazards that your community might face. Prepare for it. Plan, get your supplies, drill. As I said, this is National Preparedness Month. Take this as an opportunity. Take this as an opportunity every year during this month to make sure your kits are up to date, make sure your plans are up to date, everybody knows who they're going to talk to and when, and practice it. And then finally, think about ways that you can help to reduce vulnerability here at home, either through reducing the exposures, susceptibilities, or by building resilience. So, I'm going to go back to Jeff, and if you want to throw some questions at me. There's my contact information. If you ever want to contact me, please do. I really appreciate it. Now's the fun part called Stump the Chump. What's the biggest misperception facing the public in terms of disaster preparedness? Well, I think one of the biggest misperceptions is that this is difficult, that this is a big, complicated, scary thing. Preparedness is really something you do every day. It's thinking about what you need to thrive, not to be scared of, but being prepared, not scared, being prepared and ready to thrive. So what do you need on a daily basis? You need water, you need food, you need air, you need companionship. Disaster, it's the same thing. You just may not have those as readily available. So you want to make sure that should the normal way you get water, the tap, not work, that you have an alternate means, either a supply or you're able to go to a water source and pump some water and filter it and make sure it's safe to drink. Same with food. You want to make sure you have food. Are you going to start growing it when a disaster hits? No. So you want to have it ready in advance, having some cans of, some protein, some beans or something at least, so that you're able to, get through that difficult time. Having some games, having, what you might need, making sure that you have information, having the supplies you need for your pets available. So I think the perception is that, this is a huge undertaking. There's a great resource called Do One Thing. It's like do1thing.com. And you can go to this website, and each month they have a theme. So for 1 month it may be water. And they'll send you an email that says, do you have your water, supplies. You want to have at least a gallon of water, per person per day. So if you're doing 3 days, you want to have 3 gallons of water. If you're doing a week, you have 7 gallons of water per person. But each month, they'll send you an email or reminder. It's fairly simple, and there are ways to do this. I know a lot of people are concerned that, it costs a lot of money. Frankly, a lot of times, you have everything you need already within your house or your apartment. It's just a matter of knowing where to find it if there's an emergency. So that may be your plan is, I know this is over here, this is over here, this is over here. As soon as that alert goes off on the, the TV or radio, I gather everything ready, together. All right.
Next question. How can students get involved and make a positive impact on their community?
All right, that's fantastic. So, here in Rhode Island, you have a very strong and active Medical Reserve Corps unit led by Tom Lawrence and Aaron McDonough that are in the back of the room. And I believe they have a table out there as well. And one way to get involved is to volunteer with the Medical Reserve Corps so that they can help you to understand about preparedness. They can help you to get engaged in these activities to become more resilient and helping the community become less susceptible.
Next question. What do you think is the next big step beyond MRCs to promote public health? Beyond MRCs, so I mentioned it a little bit, and that's changing the conversation from healthcare or disease care and really truly focusing on health. In fact, I've been in a number of conversations recently at the federal level that we're taking the idea of health as a national strategic imperative. National strategic imperative. And why? Money. Health care is very expensive. But if we start focusing on prevention, if we have more of a focus on health, it's much more cost effective. Workforce. Making sure that we have a healthy workforce is very important from a business standpoint. Making sure that those costs are lower, but also making sure that we have more people that are healthy and able to work. Think of it as a strategic issue for national defense. If you have a population that is unhealthy, if you have a young generation that is unhealthy, unable to be defenders of our country, that's a strategic issue. So, again, I see that direction for health as a national strategic imperative. Captain Tosatto, what do you believe is the biggest potential global public health threat today? How is the MRC planning for possible increases in natural disasters, and what changes would you do to deal or prepare for these events?
So there's a lot of global health threats facing us. Emerging and re-emerging infectious diseases, the rise of chronic diseases in developing nations that we haven't seen before. The epidemic of obesity. I think, personally, I think our biggest threat is apathy. Is that many times we see these issues coming, but we don't do anything about it. Whether it is, our own personal health or our family members' health, we say, oh yeah, wow, they're sick, but there's really, there's nothing I can do to help with that or to help prevent it. So we do, again, need to change that conversation to get people talking about health and its importance. How can MRCs plan for possible increases in natural disasters? Again, it's focusing on disaster risk reduction because, as I mentioned, we're not going to be able to prevent all the hazards. We can help to mitigate, we can help to reduce the effects through the work that we're doing to reduce the exposures with evacuation or personal protective equipment or reducing those susceptibilities. Okay.
Which deployment taught you the most or had the most impact on you, your work, and how you do your work?
That's a good question. I've been on numerous deployments. So my first deployment was actually to the Kosovar Refugee Welcome Center up in Fort Dix after the Kosovar refugees were going throughout the Balkans, and then we had a large group of folks coming to the United States. And that one taught me quite a bit because I saw the need in this population who had never had health care before, but also I saw how health professionals and responders can and do work together very well under some very tough, emotional circumstances. So that taught me kind of personally that connection with the team. The anthrax attacks, as I said, taught me personally, and I think taught our nation, how we could respond to a bioterrorist event and what we needed to do to improve. So I think between the two of those had a tremendous impact both on me personally but also on my professional life.
On a perhaps different sort of note, how can we counteract the attraction of technology, like Poll Everywhere, to ensure our children live healthy lives?
Yeah, so I'm in a tough place with this one because on the one hand, I love technology like this because it's great getting that feedback. Or you just heard me promoting texting during disasters. Personally, though, I think we need to get people away from technology more often. I'm not saying get rid of it altogether, but get them away from the screen. We recently worked with we worked with a group called HOSA, Future Health Professionals, and they had a leadership academy in Washington, D.C. last week. And one of the things they did was a scavenger hunt in downtown D.C. Except they did something very different, is they made each of the students leave their technology device, their cell phone or smartphone or whatever, out of the equation. And it freaked them out. I mean, these were primarily high school students. But what if my mom calls? What if I... Just put it away. How am I going to... Just put it away. And they had to spend the day going around D.C., finding different things, reading maps, talking to each other, talking to strangers maybe to ask for directions. It was an eye-opening experience for them. But the comments that they received afterwards was, that was incredible. You need to do that more often. So again, it's different because, when you get so attracted, I mean, I have 4 kids in high school. They just got cell phones last year, so they were late in that curve. But they would always say, "Well, why can't I get a cell phone? Everybody has one." It's like, well, if everybody has one, you can call on their phone. If I need to reach you, I know who you're with. I can call them. But that's kind of joking. But I would watch them go with their friends somewhere, and in a group of 3 kids, 2 of them are texting as they're walking around together. That can't be healthy. Because you're losing that connection. Remember when I was talking about resilience? And I was talking about robustness and that social cohesiveness? You're not going to get that necessarily unless you're really, truly interacting kind of face-to-face. I'm all for social networks, of having those connections with your friends and families and sharing the pictures and ideas. But put it away sometime. Take a walk together and talk together.
All right. Can you tell us what advances have been taken after the H1N1 outbreak?
So we learned a lot from H1N1. It's funny because H1N1, a lot of people say, "Whoa, that wasn't such a big deal." Well, it wasn't such a big deal because public health worked. Public health worked. We talked about prevention. We hand washed. We coughed into our sleeves. We got vaccines. And so, no, there weren't the numbers of illness and death that could have been if public health wasn't there. And it's been really frustrating to see since 2010, when H1N1 was over, that all those advances that we had made in promoting public health, a lot of them are being undermined. Now, a lot of that is because of an economic downturn. Because there is less money available at the federal government, there's less money going out to states, and less money at the states, less going out to locals for public health. But we're seeing an incredible decrease in the number of public health workers. 29,000 public health positions lost in the last 2 years. It's almost a third of the public health workforce that is being let go. So, advances, unfortunately, we have great advances in technology. We have advances in our understanding and our processes, but we're being undermined in those because of some of the funding issues.
This may not be the best follow-up, but as a student pursuing a career in public health, what advice can you give?
Well, let me tell you. Be open to challenges. Be open to ideas that may fall outside of your day-to-day comfort zone. And above all, I would advise being able to communicate, both in writing and verbally. As I see, people coming in to apply for jobs, or as I go around to different areas, I am continually impressed by those that can communicate concisely and to the point, being able to, take a complex idea and being able to relay it to, the audience, being able to understand the audience and get it across. And that may be a one-to-one interaction, being able to assess the person you're talking to, what their level of education and understanding is, so that you can get that across. That's the whole field of health literacy, being able to get that message across. But it can also be at the broad level of talking to an audience or talking to a community, being able to make sure your messages are understood. Because ultimately, what we're about with public health typically falls down to trying to persuade and help to change behavior, hopefully positively. And so having those skills and communications are incredibly important.
Natural disasters in the first and second world countries pose enough health, economic, and social risk on their own. How can organizations serving the world community, such as the Division of the Civilian Volunteer Medical Reserve Corps, better manage the health risks in disaster-struck communities in third world countries?
That's a tough one. The MRC is primarily a domestic capability. So Medical Reserve Corps units are kind of a local asset for public health, emergency preparedness, and response. That said, however, we are working with the MRC units so that if they're needed outside of their jurisdiction, to be able to help out. So let's say a Medical Reserve Corps, in, I won't use Rhode Island because you're state-based, but let's say in Hartford, needs to respond to New London. Then, hopefully they have the processes in place that they can respond. Or maybe the Medical Reserve Corps from Rhode Island needs to go over to New London to help out. So making sure that those medical, those mutual aid agreements are in place. But what if it's a large natural disaster like Hurricane Katrina, where we did see Medical Reserve Corps members leave their local jurisdictions and go to the Gulf Coast? We saw that happen where they supported the Red Cross, but they also supported a federal response for HHS. Could that happen outside of the country? It hasn't yet, but I won't say no, because we almost saw it during the Haiti response to the Haiti earthquake, where there was a need for health professionals to respond. Thankfully, we didn't need to send anybody from the Medical Reserve Corps because many other international aid agencies were able to assist. Now, this question's interesting because it says, manage the health risks. And so that's ultimately something that happens prior to a disaster. So that gets into that whole concept of that disaster risk reduction that we had. And to that extent, I think we, the Medical Reserve Corps, our partner organizations, can assist by opening that conversation about disaster risk reduction. A lot of the world understands disaster risk reduction because they don't have the money to respond as we do, and so they have to focus on, mitigating and reducing risks. But the more we can advance that topic within the United States, to be able to use that kind of that voice that the United States has for others, then hopefully we can help to manage those health risks.
What role are MRCs playing in the outbreak of West Nile virus?
Great. So we've seen a number of MRCs involved in West Nile, particularly down in Texas, So MRC volunteers were involved manning phone lines. So as people had questions about West Nile, they were able to call into their health department. Volunteers were helping to answer those questions. Also, some MRC volunteers were trained to help with the epidemiological investigations. So most health departments don't have a lot of epidemiologists, but they can train others, the volunteers, to ask the questions to get that data that's needed. So they've been helping with the epidemiology.
Okay, how do you best educate the public on reducing disaster risk, building community resilience, and preparedness in general?
So hopefully doing things like I just did here is to talk about it, to get that conversation started. But then what each of you can do is serve as role models. Kind of do that homework slide that I had. The more you can do to kind of address each of those things on that homework, the better we can do, because ultimately people are going to change behavior because either somebody asks them to or somebody tells them to. And you can help be that agent of change in their lives.
How does MRC interact with other groups such as the American Red Cross?
So we have a tremendous, effective relationship with the Red Cross nationally. Does that always translate to local? Not always. But what we've done at the national level is to say we're going to work together. We have very complementary missions working together in our training, in our responses. Red Cross does a lot of disaster preparedness training. Medical Reserve Corps members can take that training, but also help to train Red Cross volunteers. Responding to disasters, oftentimes the Red Cross is the go-to organization for sheltering. Sometimes those folks in shelters might need some care beyond that can be provided by Red Cross volunteers. And that's an area where Medical Reserve Corps volunteers, medically trained volunteers, can help and assist. So again, we promote a very strong interaction, and we're in pretty frequent contact with our Red Cross partners to see how we can do even better. I'm going to give you a great example that occurred recently with the Colorado wildfires, especially around Colorado Springs. So we have promoted this interaction between the Medical Reserve Corps and the Red Cross for years. And about 2.5, 3 years ago, the Medical Reserve Corps in Colorado Springs and the Red Cross got together for some training together, and then they did some tabletop kind of notional exercises together. And then last fall, they did a full-scale exercise together for sheltering involving the emergency managers and Red Cross, Public Health, and MRC. And then this spring, when the wildfires occurred and people were evacuated, they had already knew each other. They had partnered already. They had trained together. They had drilled together. Won't say they had a perfect response, because in any type of disaster situation, there's kind of the fog of disaster and communications get broken. But they had a very good response and worked together very well because they had practiced it.
Okay, last question. This is maybe a little off topic, but we like to end on a happy note when talking about disasters. Wait for it. So how will New York City's recent ban on, quote, ridiculous-sized soft drinks transcend to other states and communities?
Crystal ball, right?
As related to community resilience.
I think this fits in to the overall idea of prevention, the overall idea of healthy living, healthy eating. This gets into the kind of the politics side of health, politics, and money, and as a uniformed member of the Public Health Service, I can't talk too much about politics. But, some of this makes sense. To me personally, I don't drink sodas because I don't feel like that's just something I want to put on my body. Do I necessarily want somebody regulating that and telling me I can't? I think that's a different question. Do I think we will see other communities, other places take up on this? I'm certain that we will. I think what we do need to see are studies. That what are the effects of ridiculous-sized soft drinks on health? All right.
All right, thank you very much. Thank you all for coming. And be sure to come next week when the Medical Director of Partners in Health, Dr. Joya Mukherjee, will be here as part of Diversity Week. Lots of other Diversity Week events going on. It's on uri.edu/MCC. You'll see the list of events, and of course, uri.edu/HC for all the other Honors Colloquium events. Have a safe and wonderful evening.
Thank you very much.